Hello, good evening, good afternoon, good day, wherever you are in the world, and welcome to the Black Belt Academy of Surgical Skills. My name is David O'Regan. I'm a retired cardiac surgeon and a professor in the Medical Education Research and Development Unit at the University of Malaya in Kuala Lumpur. Tonight, we're coming to you live from Kuala Lumpur, assisted by Dr. Apajita in New Delhi and my two senseis, Chris Kelly and Prof. Seloy in the Kingdom of Brunei. Thank you to IECHO for enabling us to reach 23 countries around the globe, and our total participants today, I believe, is 650. This evening, I want to introduce my son. We are going to talk about assisting. Now, what's interesting, both of us practice martial arts, and we've been studying Judo for the past 18 months. And that means we have to practice together, swing swords and swing sticks at each other, but we need to understand the timing, the spacing, and anticipate each other's moves in each of these katas. When you're swinging a broomstick, but it's made of white oak, towards somebody's temple, or their head, or here, the uta, all of them are potentially lethal blows, but have to be blocked in time and appropriately with the weapon on the other side. And it has been close in this distance in rehearsing it. But it's choreographed and rehearsed and anticipating. And the more you practice and the more you rehearse, the more you anticipate, the better the kata becomes. And Alistair, your perception of this exercise and the my
perception of this.
Yes, please.
Well, in martial arts, we must gauge the distance between ourselves and our opponent. If we are but half a foot or a few centimeters away, our strike could miss, and that could be, in a real combat situation, be fatal. If we are a few centimeters too close or too far away, we could indeed hit our opponent and injure them.
And that's why it has to be timed, precision, and we have to understand what we are doing all the time. But assisting, not many of you would be doing martial arts, but assisting is likened to dancing. Now, a good dance partner is someone who makes the dance feel easy, connected, and enjoyable by communicating clearly through movement, responding to sensitive cues and gentle nudges, adapting naturally to their partner's style and ability. They move with musicality, maintaining balance, control, and good posture so that the partnership feels light and stable, while showing respect for personal space, comfort, and floor awareness. From respect point of view, in martial arts, we always start our katas by actually bowing to each other. That is before and after katas and before and after entering the dojo. But this awareness, above all, and assisted, they bring a positive, encouraging attitude that helps their partner feel confident, relaxed, and inspired to dance. Some of the greatest dancing pairs in history are remembered not only for their technical brilliance, but for their chemistry, innovation, and influence in dance culture. Famous of these, of course, is Fred Astaire and Ginger Rogers, the most iconic partnership in film history, redefining elegance, romance, and storytelling through dance in Hollywood's golden age. Ginger Rogers apparently was not a very good dancer, but she was an excellent follower. And of course, Fred Astaire, with his brilliance, set the stage. Second partnership is Gene Kelly and Sid Charisse, famous for their athleticism and dramatic power, particularly in the films Singing in the Rain and Brigadoon. Rudolf Nureyev and Margot Fonteyn, a legendary ballet partnership whose artistry and emotional depth revitalized classical ballet worldwide. Each of these partnerships changed the way dance was performed and seen and understood, and set standards that inspire dancers today. Not on the floor, but on a slippery surface, you may remember Torvill and Dean, who going 10 in ice dancing and were famous for transforming ice dancing into a form of dramatic storytelling in their bolero dance at the Olympics, combining extraordinary technical precision with emotional expression. And that breakthrough came through in the 1984 Winter Olympics with bolero, with a record-breaking score, including multiple 6.0s for artistic impression, and they won a gold medal. The routine was revolutionary, slow, hypnotic, intensely expressive, and pushed the boundaries of what ice dance could be. And what set Torvill and Dean apart was their seamless partnership, impeccable timing, and ability to make choreography look effortless. Their chemistry on the ice and their innovative approach turned ice dancing into mainstream entertainment and inspired many skaters for today. Dancing champions work in harmony, leading and following, imbuing the movements with flow and rhythm. In the same way, a good assistant will over time become attuned to the nuances of a surgeon and the surgeon's lead. Sometimes this will be intuitive, but most of the time this needs to be practiced. And they're important principles to the dance of assisting. And the principles make this dance of surgery very important because both rely on verbal and non-verbal communication, timing, trust, and situational awareness. A good surgical assistant moves in synchrony with the lead surgeon, anticipating needs, responding subtly to the cues or smoothly to subtle cues, maintaining precise control of the instruments with good handling and with rhythm and flow of the operation. Like a skilled dance partner, the assistant maintains balance, posture, economy of movement, and keeps the operative field dry and clean, free of blood, by dabbing with the swab or using the sucker. They remain aware of the space by not bringing their hands into the operative field, but keeping on the outside with a lateral hold and not a pull, maintaining traction and counter traction, equal and opposite, everywhere the surgeon moves. The sterile field, the patient, and the wider team are part of the floor, and you need to be able to adapt to the changes in tempo, the anatomy, the operative difficulty. Above all, a good assistant brings calm focus, reliability, allowing the surgeon to work with confidence, knowing that every movement is supported and understood. And the main principle of assisting is anticipation. And you can't anticipate unless you've seen the operation and seen the various steps involved. But all surgeons start their career in theatre assisting, and there's some fundamental rules on the distance and spacing, as with dance partners, that you need to understand. So if Alistair, as the operating surgeon, moves to his left, I've got to move to my left. If he moves to the right, I've got to maintain the right, because our shoulders have got to be parallel at every stage. I must never cross my hands, and likewise, Alistair should never cross his hands. My hands do not go into the operative field, but stay on the outside. The assistant should really be thinking one step ahead and should never stand at the table without an instrument in the hands. And the most appropriate instrument for a surgeon to use all the time is a pair of forceps. The forceps and the forceps or your fingers. You never grab, you never snatch, you never reach across the red midline, and if uncertain, wait for instruction. You read the operative field in the workflow, and you should be prepared before being asked by anticipating. Assist before you ask, essentially. And good surgeons make good assistants. Part of that is understanding your primary technical role is to provide a clear, stable operative field without any sucking the bleeding and dabbing with a swab, to maintain optimal visualization, to retract gently and precisely, and avoid tension, tremors, and tissue trauma, adjusting the angles dynamically as the operation progresses. You see, good exposure equals faster, safer, deliberate surgery, and using the swab and the sucker is important. As with the surgeon and what we've taught in the Black Belt Academy, the assistant likewise has to handle tissues with care and be mindful of that 6 million newtons per meter squared that will occur if you're pinching a pair of forceps of 30 newtons with 5 millimeters squared at the tips. The other thing is, sometimes it's necessary to keep the field moist to stop it drying out, so a syringe of saline may be used and is appropriate. Remember, as an assistant, there's a correct instrument for every task, and you should be aware of what instrument to actually be holding and passing at the time. There needs to be economy of movement. Avoid unnecessary movement. Keep your hands on the outside of the operative field, assisting and not interfering, remembering that to the surgeon's right is usually the scrub nurse, and that is the area that sharps and blades are passed and won't betide you if your hands go in that area, because you might indeed incur an injury. So instruments likewise need to be passed deliberately and safely at all times. And with all these principles, you are helping the efficiency and safety of the operation. You are reducing fatigue and possible error. Remember, as Alistair stands, if I stand here as an assistant and Alistair stands here, point at the operative field, Alistair, and I point down, I'll just adjust the camera, and we're going to be operating on the chicken leg shortly. But you see, that field of view for the surgeon subtends an angle of 90 degrees to mine. So therefore, I am providing the necessary 90-degree view to the surgeon. And that is vital, that the assistant feels comfortable speaking up and saying, that doesn't look quite right. Or the best thing to say is, could you explain exactly the orientation here? As I did with the consultant surgeon when I first started at the Brompton Hospital, he was putting in a stentless aortic valve and a homograft, and I was trying to orientate the posts and pillars with respect to coronary arteries. It wasn't right, but I couldn't say, excuse me, that's wrong. But I said, could you explain the orientation of the valve? Yes, yes, was the reply. And 15 minutes later came the answer, now understand why you asked the question. So the assistant is the surgeon's second set of eyes. And surgery is a team activity. You can't do it without an assistant. And therefore, surgeons are beholden to actually treat their assistants with respect. Acknowledge instructions, clarify uncertainty immediately, speak up if there's any safety concern, and always use playback and closed-loop communication. Well, the other part of this is, as in karate, we bow before we start, and we bow at the end, and respect is evidenced by being punctual, being prepared, know the procedure, and know the anatomy. Respect everybody, and if you don't know, ask. Every operation that you're going to do is a learning opportunity, and I call it look and learn. There are many things surgeons do, little tips and tricks, that if you're not watching carefully and you don't ask, can you explain why you do that, or what are the difficulties here? you will not understand the elements that often become tacit within the expert surgeon. You can then reflect on your own performance, seek feedback, and improve deliberately. Rehearse your anatomy pre-op. And I think one of the useful things to do in an operating theatre is ask, how do you identify tissue planes? And remember that the question why is always an outstanding and excellent question. So I'm actually going to assist Alistair in this process, and we are going to operate on a chicken leg, and he is going to do the operation. I hope that you'll understand that as we're doing this, our opportunity to develop and explore will become evident. So, Alistair, are we happy to start? There you go. I've got 2 forceps. Alistair is going to make an incision, and I can delineate incision through the skin from there to there. And Alistair's been part of the Black Belt Academy previously, so supporting it with your fingers and lightly stroking the skin, not so hard, just very lightly through the skin. You'll feel it separate underneath you. Fabulous. A little bit further. Okay, a little bit further there. Okay, so having gone through the skin, okay, I'm now going to cut that bit. Okay, hold your forceps. I am providing traction and counter traction all the time. Now, we're going to develop this plane, and to help Alistair develop the plane, I'm holding with the forceps, and I'll probably use 2 forceps because it is fascial tissue. I'm holding it up to enable you to stroke your knife along that plane to, remember, it's parallel to the surface. That's it. And you're stroking it so the blade is touching. That's it. Very good. Keep going. And I'm going to move around here and you can cut down there. Okay, cut through the skin down there. And I'm providing traction and counter traction all the time. So wherever Alistair picks up, I'm understanding where he's holding. So let's come down here. You pick up there and you can cut the skin again there. So now you're going to take the skin off all the way down. So see if you can take the skin off. You can use a combination of knife or scissors, whatever you please. What I like is the way Alistair is holding the knife and brush it, as we said before, against that surface. Just gently brush it. Keep on brushing. And I'm maintaining traction. Your forceps are gently holding that away. So it's providing traction and counter traction all the time. So I'm trying to anticipate his movements. And also at the same time, I'm with a trainee surgeon, I would be actually directing where they want to go. And these are sort of invisible cues. I'm actually holding the tissue up. Very good. Keep going. And this side as well. Let's come down here. Okay. Good. Bit more down that here. Right. Now we've taken the skin off there. You hold it there. I hold it there. Do the same down this side. There you go. Blushing. You see how the traction and counter traction enables the surgeon to accurately develop a plane. Hold it there, please. And let's come down this side here. Okay, good. Well done. So you can see here the muscle fibers. And why don't you stroke the knife along the line of the muscle fibers and build a zone. Remember, use your, okay, I'll provide traction the other side. You stroke it from there to there down the muscle fibers. Just gently through the layers, okay, but further. Okay, and I'll provide traction. And we can come a bit deeper through that, can't we? Good. Keep on the same plane, not too deep. That's it. Perfect. You can now see this muscle layer coming off. And if I put my forceps underneath, you now can clearly see how to cut that. There you go. Marvelous. And we can cut through that side there. So I am actually assisting Alistair by using my forceps as a probe to delineate the plane. So why don't you use the scissors and come around and take that bit of muscle off there. I like the way you're holding the scissors. Good. Cut that. Snip. There you go. Snip there. And I might actually just zoom in for you from home and continue to talk. So note that my hands are on the outside, Alistair's hands are on the inside. So let's come around here. Okay. Okay. So there we go. That is maybe a vessel underneath there. And I can use a Leahy. No, there isn't. We've got that off. Okay. In the same way you've developed the planes, let's see if we can take a knife against that plane. And again, I'm maintaining traction and counter traction. So Alistair can actually stroke his knife across that plane. That's it. So it's keep it flat with the surface like that. Okay, good. There you go. Brilliant. And this side as well. And we can actually, there you go. You see how we're using the tissue planes and we've taken that bit of muscle off. Let's come this side. You hold it there. I'm going to hold here and here. Get a scissors perhaps. And let's dissect that off. There. Okay, you might need to move around the table a little bit to your left-hand side. Okay, let's come around here. There's a fascial plane there, isn't there? So I'm anticipating all the time there's a fascial plane there that you can develop with the scissors. You see that? There you go. Well done. Open, split, and take out. Open, take out. Now cut down that one between our forceps. Keep going. And what we're going to do is take that off. Now, at the bottom of this, you might see yourself here, we have got a neurovascular bundle, haven't we? So now with your scissors, we don't want a sharp knife. What we can do is actually assist this by putting a retractor in there and opening that up a bit further. With your scissors, opening and closing slowly without cutting, develop that plane. Open it, and there as well. Okay, cut that. And keep developing that plane. As you are, don't grab that, that's the nerve there, and that is the vein and the arteries there. So come down that side, and you see that. Well done. Keep going, you can clearly see that and develop it. You can nibble with your scissors.
Where should I place my forceps?
Counter traction, good question. Just nibble, that's it, not too aggressively. Come down this way, see that? That's a tissue plane, and you can come down this way and nibble along that plane.
Can scissors be used in the left hand?
No. Okay, no. So you need to move your body position. I know the light is in the way there. Move your body position and see if you can come around that plane. Don't open them up too far. And you want to just be able to do. So what we've done here is actually, you can see, just move out the way again. By assisting and anticipating, we have now got the neurovascular bundle of this chicken thigh dissected out. Didn't take very long, did it? There you go. You can now separate it. Another tool to use is a pledget and a peanut on a Roberts. And you can gently brush that fat tissue away there and brush it away and see, just on the vessel itself. That side, you brush it away. Okay, you might need to cut it along there. You see what I'm doing? I'm just brushing it there like that. Okay, cut. You can see the vessels. You can see the soft tissue. You can cut that. Nibble. That's good. Nibble with the scissors. Very good. Okay. Now you can see it disappearing down that hole there, isn't it? Yeah. You can see it disappearing down the hole there. You can get your scissors in and out. See how I'm using my forceps to actually put it in, and I'm gently expanding the space. You can do the same with your scissors. And what we should do, let's take this bit of muscle off here, shall we? So you might cut that with the scissors, and let's take that muscle off there. Take that tendon off there. Yeah. So trying to progress the operation as a surgeon and taking a train. Okay, good. You can see the plane developing there, can't you? So I'm going to hold that up, and you can provide counter traction there, and I traction there. Okay. And he's moved to his right, and I'm moving to my right, so our shoulders are parallel. Okay, pick that up. You can cut through that. You can see that as a tendon. Very good. And cut it again. Okay, and now you can see that space is opening up, can't you? So let's cut through down that fascial layer there. And we can take that bit off. Good. Good. So I'm anticipating his moves, and I'm trying to actually make it easier. And because I know the anatomy, well, not of the chicken leg, but I can recognize tissue planes, I can direct my trainee surgeon any which way is necessary to actually expose this by employing the principles of good assisting. Now, the nerve is running there. So let's see if we can avoid the nerve, but just there, if you cut on the muscle side, just that bit there, okay, and let's see, we can take, there we go, we can cut that bit. There's a tendon. Let's cut through this bit here. And here, that's that all there. I can hold up different pieces, and you can cut down the middle in this here. Okay, good. I was happy there was nothing there, but that, and otherwise I would have said, don't take such a big bite with the scissors. There you go, doing very well. Cut through that tendon there. Okay, now we're coming down as it comes past the joint into the leg. We can cut a little bit there. See that? So I'm using my forceps as a tool to support this dissection. And we're going to open separate down there. Just careful, that's the nerve there, you see? The nerve is right there. So keep it on the muscle side and separate it in the same parallel plane as you can see here. Yeah, just there. Okay, and take it out, separate down there. So as Alice is doing, he's separating with the scissors, opening them up and taking them down. There you go, we can take that. Okay. There's nothing there. I can put my forceps underneath, and we know that's not any significant tissue. So why don't you just use your cotton bud again to explore where that's going down there into the leg. Just push it down as you would here, but you're using a pledget, and we're brushing the tissue away. But I think you can see here we have got fantastic femoral canal. That's the femoral nerve there. You can separate that out. You can brush it off with the rest of that away. Just brush it off a little bit more vigorously down that side and that side.
Push it off the muscle.
Yeah, brush it off and clean all this loose areolar tissue off. Okay. And as part of assisting the process, often we don't want to cut the nerve, we want to clearly see it. And slings are very useful because they're soft, but you never put any traction on nerves because you cause a neuropraxia. But if you've got a bundle that's in the way and you want to hold it out the way, simply putting a sling around it and putting a rubber shot on it helps it out. So I'm anticipating and trying to clear the field. If there was bleeding, I would be sucking. If there's diaphragm, I would be sucking the smoke. And to help with the dissection, I would help dab and remove the blood from the field of view. And I think we have actually traced that nerve. There it's going down, bifurcating there, isn't it? You can see the nerve there, it's bifurcating there. Let's see if we can explore that further. There you go. It's branching there, isn't it? Can you see that? There's a branch, I think, just there. Yeah, there you go. There's a branch just there. So we've got the branch there, branch there. There's a branch probably, as you can see in that lot. And because there's a branch, and because there's a little resistance to gentle movement, the areolar tissue is there, but it feels string-like, and that's the nerve, and it branches there. The vessel is here, and if you try that with a swab, but hold the forceps on the loose tissue the other side. Yeah, that fatty tissue there. Hold the forceps, hold that fatty tissue here, the tip of my forceps. Tip of mine, yeah. And see if we can actually separate the artery and the nerve, the artery and the vein. And I'm not sure. I think it's the vein. The two are right next to each other there, but on top. So we have actually dissected out that femoral canal. The whole idea, put your hands in the field now, put your hands there in the middle with your forceps and your left hand and your scissors. If you put your hand in the operative field, I'll zoom back a little bit to demonstrate. And my hands move to your left, move to right. If I was actually also cutting or moving my forceps, I would have to move my forceps left hand, right hand, particularly of following. And there you have it. We have exposed the femoral canal of a chicken leg. And the whole idea, as I hope you saw there, it's much easier to do this as a surgeon if your assistant is anticipating and enabling and exposing, holding, retracting, sucking, etc. Alistair's now going to put some stitches in, and I think what I'd like you to try and do is, why don't you start just gently pulling that together, all right? So let's give you a stitch, because part of this is also for you to understand the stitching process, not you, but the assistants. So there you go. You need a forceps, and it's best to stitch towards yourself from this end to that end. Okay, off you go.
Towards myself.
Yeah, from there down towards there. So start your stitching there at that corner and down towards your right arm.
How do I use the forceps? Holding together.
Well, your assistant should actually hold it, but we're going to respect the tissues and we're not going to grab it. You're going to lift it up. You can take it through there, needle through that.
Through, yeah.
Yeah, good.
Pronate.
Yeah, pronate, very good. Take the needle. Okay. Well done. Rotate, don't pull it out. Rotate it with the needle. Come through that side. Then you'll pick up the fascial layer there. Come through there. Actually, let me see. I think let's start further down. I think because we cut the fascia there, you can see the white to white. So let's take that out and let's come further down. No, you can keep the needle on. Sorry. Yeah, keep the needle on. And I've just spotted the fascial layer further down. Good. All right. So now you can see that white fascial layer there?
Yeah.
Yeah, take a needle through this lot. Yeah, okay. Take the needle. Hold the needle and pick it up again and deliver it on the curve. Okay. Okay. And then take it right through there. Yeah, through there. Bit deeper than that. Good.
I'm encountering resistance.
Right there. It's on the cartilage. Find a soft spot. There, at the base, underneath my forceps. Not too close to my forceps, but deeper. Okay. How's your knot tying going? You want to have a go?
Inexperienced, but can have a go.
All right, have a go. I'm impressed you're palming your needle harder. So take that through, and yeah, just hold the needle on there. Just hold it on the needle, pull it through. Okay, and there you go. With your left hand, tie a knot. Let's see what you can do.
Hold here.
Okay, and pull it all the way through. Okay, okay, go on then. A bit shorter. Okay, good. Okay. Flick that short end through. Good. All right. Just make sure it's coming down flat, which is okay. And put another one on. That's good.
Should I be holding further down?
Yes. And I am holding for you. Okay. So you'd normally put a number of throws on that. So remember, throws over the top, and you put a number of throws. And for deep sutures, because of that is spiky, I'd make sure I bury it. Now I'm doing this to actually demonstrate how to follow. So if you look at the length of this suture, you won't be able to see it on the camera, but I'm holding it 2/5. I'm holding a lateral hold and allowing 3/5 space to actually rotate and use it. So you use the forceps, I use the forceps, and now you're going to stitch going through both those layers together all the way around. And by holding, so 1 centimeter apart there, and there, yes, rotate the needle back and rotate it through.
Through one plane.
Yeah, both of them together. You can do both if they're together. Unlock it. Remember, the needle is held in position, so don't pick it up with the forceps. Just continue to deliver it. Push the needle through first on the rotation. Push it through a bit further. All right, now you can pull it through a bit further on the other side. Pull it through just gently, and then you can pick it up and do it again. There you are. Okay, stop there. Now turn your needle holder around, pick it up. That's it, perfect. Continue on the rotation, and you're ready to use your needle again. Well done. And what I'm doing is a lateral hold. Okay, so Alistair's going to stand on his right foot. I'm going to keep parallel to him, and I'm keeping, you see, you won't see it, proline's got a memory on it, and it drops and loops. Two things you mustn't do with proline is lock your finger round, because if you lock your finger like that, it pulls out of the tissue. So it's a lateral hold between your finger and thumb. So if it gets pulled out of the tissue, it's there. Really, you should anticipate the surgeon. You hold it until the surgeon starts pulling and it slips out your hand. The surgeon then holds the suture out in the direction and the tension that's required, and you simply apply your fingers. You don't reach in and grab and pull. That direction and tension is by the surgeon, and you've got to read the cues. Carry on. So 1 centimeter apart, keep going through there, through both layers, just 1 centimeter. There you go. You can do both layers. 1 centimeter deep, 1 centimeter, 1 centimeter deep. Okay, 1 centimeter deep and 1 centimeter apart. Okay, and go through both layers. You can hold that layer if you want and rotate them. Just let the needle do the work for you. Okay, keep pushing the needle through. Good. And then do the same again about the pickup. Deliver it on the curve gently, and then not, and just partly, and then reapply the needle when, keep on the curve Okay, reposition, take it through. Good, reposition your needle. And I keep the tension on that suture until the needle's repositioned. And I can see Alistair has remembered the position of the needle on the needle holder in the 1, 2, 3 principle. You take the suture and I follow again in the direction. Keep going. 1 centimeter apart, you can hold that edge and I can hold this edge. And you're coming 1 centimeter from the last one and 1 centimeter deep. And put your needle down 90 degrees across what you want to stitch first. So if you put your needle down, put your elbows by your side. And just close that angle a little bit. All right, let's close the angle a little bit. So you'll find it a lot easier if you close the angle a little bit, put it down. Okay. And I'd say the table is probably a little low for Alistair.
Agreed.
Agreed. That's the problem of being 185 centimeters. There you go. You hold that side gently, don't grab it, just reflect it.
Yeah.
Come through this side. Yeah.
Yeah.
Yeah. And do it in 2 probably. Do it in 2, come out into the middle. Okay. Don't do, yeah. Just hold it, needle in place, apply the needle holder and take it through. I'm maintaining the tension all the time. Take it through. And you, okay. And I also might help place the suture. Okay, through that side as well. So right now we're rehearsing some of the basic surgical skills that we've discussed previously. But throughout talking, my hand is up here holding this 2/3, 1/3. So Alistair doesn't trip over the needle, over the thread. Come through here again. Okay. You can hold the needle, keep pushing it through. Good. Keep it on the curve. Put it through, take it out in the direction it's coming through to the tension that you want. Well done. So that is the principle of assisting. You want to hold the suture out the way, 2/5, 3/5 in length, and you maintain a lateral hold without tension. The other thing is that you need to understand what I call the semaphores of surgery. The surgeon might hold the one end up and say, put a clip on it. Okay, and you put a clip on it. And the way you put a clip on is gently remembering the palps of your fingers are in touch with the instrument, and you put a clip on the end and put it down. That is maintaining traction in itself. Sometimes the surgeon will hold it up, and holding up will indicate whether you cut it or not. Now, cutting requires you to understand as an assistant, again, how to hold the instrument. Balanced on your fingers, you never open the scissors any more than necessary to do the job, and that's about enough to cut the suture. You don't come sweeping in from the side, like out of the operating lights we have, and cut the suture and cut it. You bring your scissors into the operative field, you hold it open and you cut. Could you hold that for me, please, Al? Just hold it in the air. If you have difficulty or tremor, then you can use your forceps. Bring your forceps in, place your scissors on the forceps, and then execute a cut, close the scissors, and take away. This is not a hurried movement, it's deliberate. Do not cut it too short. Beware in cutting sutures that you actually cut them at the appropriate length. And that for a monofilament should be about 5 millimeters long. So the principle of the system is all the time trying to ensure that your surgeon is actually able to see, able to conduct the operation, and your assisting is anticipating and moving accordingly. So you can continue stitching if you wish. I'll continue assisting, but we'll ask our fellow sensei Chris Caddy and Prof. Seeley, that's a perfect angle, less, okay, and continue along that. So please, 1 centimeter in and out, good. And Sensei Caddy is online. What else would you actually add to assisting then, Sensei Caddy? For somebody who doesn't do surgery on a regular basis,
Not at all.
like not at all, you are demonstrating remarkable skills for a complete novice. And I'm impressed, okay? What I do is actually keep that out to the side and come through that side. Carry on. So you're making observations, Mr. Kenny. He's gone quiet. You need to continue the conversation and add to your discussion. Let me just take you down on the assisting bit. Okay. Off to the side. Carry on. Are you on mute? Or very quiet? So I'm watching the operation and I saw there's a little loop appearing there. So very good. Keep rotating that needle. Remember to unlock the needle holder before it goes through. Again, I can see the loop is in the way and I'm anticipating that and picking it up. Okay.
Could you expand upon unlocking the needle holder before?
Well, it's like throwing a ball. So as you've unlocked the needle holder, when you pronate, you can unlock it. So it's not on the ratchet. Okay. So it's not on the ratchet. So you place your needle 90 degrees across what you want to stitch. So it's aligned. You can see the 90 degrees there. And because my shoulders are parallel with Alistair and he's standing on his right foot and I'm standing on my right foot, I can reach across the table, but you can see the midline between us is here. So I'm not reaching across the midline, it's rotated because Alistair's on his right foot. Continue on. Mr. Caddy is not talking. In and out. In and out. All the way through. Go on then. Okay. That's better. Good. Keep rotating.
Is that any better? Can you hear me now?
I can hear you now, yes.
Okay.
Okay, deliver it partly before you take it out, and then you can apply the needle holder. So
My observation was that, David, when you looked at the operative field, you knew exactly where you were going to put the first stitch in.
yes,
But Alistair, not being a surgeon, didn't know where to put the first stitch.
true. So
You then put
this
the
is
first stitch in, or he
yeah.
put the first stitch in, but it was not in the right place. So you took it out and restarted.
Well, that's because I misdirected him, to be honest.
Yeah,
Because
no,
I
so
spotted it.
it's all your fault.
It's all my fault. It's the assistant's fault.
Yeah.
But it's the surgeon's fault. So through there, okay. Place your needle down 90 degrees to what you want to stitch. Rotate it back, and then 90 degrees into what you want to stitch, and continue the rotation. And here you've unlocked it. Push it through. Push the needle through. You're pushing it through. And now don't pick it up with the forceps, pick it up, deliver it gently until it's on the halfway, stop there. Now put your needle holder on and continue the delivery. Perfect. All right, use your forceps to do the spacing.
Between each stitch, almost reposition the needle.
Yes, well remembered. That's exactly what you need to do.
I was asking.
Yes. You won't know what to do. And you note that I've actually got my elbow out the way. And it reminds me of my time, carry on, working with Stephen Westerby, who did some of the fantastic aortic and Marfan syndrome surgeon, who did some of the first work with aortic conduits. And I was assisting him, and the camera was from the top. And it's one of the profound lessons is if I'm not grabbing that suture, you don't grab monofilaments, I'm just holding it out the way, apply the needle holder, continue on the curve, perfect. And when my hand got in the way of the movie camera, did you see, you can't see, when it got in the way, I got wrapped on the knuckles with a tubing clamp. And a good reminder to keep your hands out the way. The other kind of excision I worked with Jim Monroe is called Gentleman Jim. And when holding a 7/0 proline on a 2 mm fine coronary vessel, you can't afford to have your proline pulling out or tearing from the tissue. And the tension on the suture is of critical importance in particular in any tissue, but is very visible in vascular tissues and vessels and coronary vessels. And his phrase was, it's a lateral hold and not a pull. So the vector, the direction, and the tension is actually determined by the surgeon. The assistant just puts their fingers in place to ensure that, and I'm going to hold that over there so you can deliver, to ensure, okay, pick up, brilliant. Now that is excellent. Well done. Continue. Okay, a little bit deeper there.
It appears this muscle is higher up.
No, it's not. It was. It was. And you're bringing it together. Keep going. So this is part and parcel of understanding where the surgeon is in an operation and actually how to hold the suture and follow it. Okay. And I am actually marveling at the fact that Alice is paying attention to the needle angle as we stitch, and he's mounting it at the tip. Okay, rotate, point it in, okay, and just rotate it all the way through. Don't push it in, don't drop the needle holder, just use the rotation. And out, okay, keep rotating. Okay. Anyway, it's angled, so if you take it out and place your needle 90 degrees across. So from your experience then, Mr. Caddy, what do you think are the essentials of assisting or good assisting? What would you like to add?
Patience and presence. So you
Patience and
need to
presence.
be watching what's happening in the operative field, but also be aware of what's happening in the rest of the theatre.
Yes.
So you are the eyes and ears for your surgeon as well.
Okay. I'll rotate through. Okay. Keep pushing it through on the curve. Once it's there, deliver it further, pick it up on the right spot, and then you can do it again. Good. Just maintain the tissue out in the direction.
Uneven distance. So.
That all comes with practice. So I wouldn't worry about that. But I think what we've hopefully demonstrated to you, that Alistair hasn't operated before. You're not a surgeon. But can I ask you, how did you find that dissection? The exposure, what did you think?
Well, it certainly requires close attention.
That's not the stitching bit, but about the dissection and exposure.
Well, observing it, you made it look very easy. So as the assistant, you basically told him what to do and he just did it. And it was then iteratively, you'd open up the wound a little bit more, a little bit more, a little bit more, stop.
Yeah.
And then by putting tension on the skin edges, the tissue planes just opened up in front of you.
And that is the essence of what I think an assistant should be doing in the helping of the dissection, is the traction, counter traction, and helping the surgeon reveal the tissue planes. Okay, then you can lock it there. Let me hold the suture out of the way. There you go. Is anticipating and watching. And I think when you're training surgeons, this is where a surgeon training somebody for the first time doing an operation, you are actually doing the operation, and all this trainee is doing is following commands, and
Yeah,
you're pointing
but
everything out. But they're learning by doing as well and
and they
feeling,
think they're doing the operation.
and they think you think you're doing the operation. That's interesting.
Yeah.
But by
So,
facilitating and exposing and everything else, compared to when I did it by myself a few weeks ago, dissection, we said you have to have an assistant. We got to that femoral canal significantly quicker
quicker.
because I had an assistant, and there were four hands doing this job. That's the difference. Were we hurrying? Were we making fast movement? No, but we were making purposeful movement. And I was anticipating and looking at the movements Alistair was making and directing where to cut, when to use the scissors, and when to use the blade. Those decisions, as a surgeon, you make yourself. But one of the decisions you have to learn as a surgeon is not only the technical skills of doing this, but also knowing, once you started learning the operation, is how to direct your assistant. And those directions are actually simply coming back down to a dance, how to actually manipulate tissues and move around, and how to hold. So these simple instructions will help guide. And 2/3, 1/3, finger holding, lateral hold, not a pull, keep your shoulders parallel. And I'm not parallel because I'm talking to you now, but I would otherwise be this direction, holding with my right hand and not in Alistair's space across the table. Alistair's 1.85 centimeters tall.
1.85 meters.
1.85, 185 centimeters tall. So actually the table's too low for him. And he's standing like a giraffe now to actually get to the right height by him keeping his back straight and neck straight without bending down. The person who dictates the height of the table is the operating surgeon. But the operating surgeon cannot ignore the height of their assistant. Don't block it, and come take it through and let go. You got locked it. Drop the needle a sec, please. Okay. All right, and take it. So because Alice is 1.85 centimeters, it's important that I stand on the table's at his height, and I stand at a appropriate stool to also ensure my arms and hands are at a functional height as well. Michael, again, who's the sensei of a cardiac surgeon in Hull, he's slightly taller than Alistair. No one had ever stood on a stool to enable him to operate. He always kept the table at the height for the surgeon. Silly. I was the first surgeon ever to stand on a stool to enable him to operate at a comfortable height. Our sensei, Prof. Sile, is with us this evening. Hi, Sile, how are you? You're on mute at the moment. You're on mute. Do you want to take the microphone off? You're still on.
Yeah.
There we go. There, we can hear you
Hi,
now.
good evening. Yeah. Good evening, Prof. David and Prof. Chris and Alison.
Yeah.
Sure. Thank you very much, Prof. I think we've been mentioning this in a few sessions before as well, respecting each other in operation theater. I did mention about that also, to adjust the table heights and all that. So you did mention that just now. Not only we ourselves as a surgeon to be comfortable, but we have to think about the comfortable, how they are, convenient in the theater. That's a good point, Prof. Yeah. I think I'm following the techniques that you are teaching, taking him along during the surgery. But I would like to add a little bit more from the other aspects as well, you don't mind. Yeah.
Please.
To me is that, yeah, because like as you mentioned, a good surgeon become good assistants become a good surgeon. So you have to keep assisting, you have to keep assisting, keep watching, anticipating, in many times, and then only you will start, the surgeon will start allow you to start cut. And it's not that sometimes like we did not we do not have ourselves allowed by surgeon to start cutting off, many times assistant then only they allow to start the skin cut, in front of them. So it's like first the step is being as a assistant, good assistant, is that start from observers. So from the third assistant, then become second assistant and become a first assistant, and then only you will be operating half with the surgeon. So these are the many steps, for the months and years, then only you will have it like holding the knife, by on your own.
Sure.
Yeah. This is the first point. The second point is that this is what my teacher again, Prof. Siva, to become a good assistant, he been training me pre and intra-op and post-operatively. So the meaning is that in order to assist him, you must know the case before you come into the theater. So let's say in a clinic, when he saw the case and a patient, and then I assisted him in the clinic, then listen, what is the case, what are the investigations has been done, why this surgery is needed, and what the planned surgery would be. And anticipation, sometimes like virgin abdomen, we may not have anticipated for the adhesions. Maybe someone who had it 2, 3, 4 times previous surgeries, and then you have to anticipate for that the difficult surgery. So it's like you have to prepare your mindset. It's a 1 day before the surgery, before to assist the case. Yeah, how difficult it sets will be. Of course, you must have a good sleep at night. And then usually these difficult cases, we start in the early morning, like 8 o'clock as a first case in a theater. Necessary, we put a stand in, for the ureters, not to injure if you have a facilities. But if you don't have a facilities in a district hospital, we'll just go ahead with that without standing, but by observing not to injure the ureter and all that. But intraoperatively, this is what you've been teaching. But I think the most important, like the dance, when we dance, before we dance, we bow, we practice, we know that this is what dance would be and what music will come. All right. But the surgery sometimes not happen like that. Sometimes the music, the melody must change. Because like from easier part, and then it will become a difficult part, in a surgery. So that anticipation have to be done by the surgeon itself, and then also by the assistant, and then the rest of the team, anesthetist, instrument nurse. Make sure there is some other instruments, necessary instruments are in the theater. If you needed something and then you have to look for another instrument in another theater, it takes a time. So that is during the operation, that intra-operation. But what I noticed and what I'm practicing nowadays is that what my teacher demonstrated, he did not say, but he demonstrated, Prof. Siva demonstrated me. We must be in the theater half an hour before at least, and must be inside the theater before patients sleep, and greet everyone like anesthetists and even instrument nurse. Good morning, how are you? Have you have a good breakfast? All these make the assistants, all the assistants, not only your assistant, even instrument nurse and all the whole theater team, make them more comfortable with you, more happier, in a good mood. So if you encounter any difficulties, they are ready to happily to help you. Sometimes like the surgeons, some surgeons, I must say, I'm sorry. Some surgeons are very moody, you
Yes.
know. So when there is any problem and any issues, and then they start become moody and then started scolding the nurses and the assistants and all that, and make this environment become more panicky.
Mm.
So this is what we have to demonstrate. I was learned from him, how do we cool down during assisting.
Mm.
So then by learning from him, now I try myself to become, this point of time, become a cool as a surgeon in the theater. As you know that sometimes the cesarean sections, wartime hysterectomy, the bleeding might be encountered. You know, you expected only 500 loss and then mil loss, and it can be 2 liter loss like placenta previa and accreta and all that.
Mm.
So we must demonstrate our assistant how to cool down in the middle of the emergency as well. So it's like the assisting skill is not just a surgical cutting or assisting skills, but we have to learn the other skills as well. Thank you very much.
Very important, and that's why it's important that the mindset of the surgeon is there. And there's very little that will be an absolute disaster that you can't put a finger on, put your instruments down, take a brief breath, go back to the basics. But for the operating surgeon role models that. And that's where you learn good behaviors, bad behaviors, but help with the situational awareness. And as pointed out, as we reinforce, put your finger down to that line. There, we have got same operation, two perspectives. And if the assistant's seeing something, it's highly unlikely that you're not seeing something. And from a surgeon point of view, you've got to encourage that speaking up as part of that. But I do like being in theatre beforehand, before the patient's there, but it's also part of the checklist. But in that moment, you can define what the trainee is going to do or not do during the operation, and actually say, the assistant's going to do that, or at the end of the operation, I'm going to teach the assistant how to put skin stitches in. And you can make that an agreement beforehand and part of the expectation of theatre. Obviously, or if all goes well, because as the operating surgeon, you've got to be mindful of the needs of everybody in theatre at the time, and keep an eye on the clock and lunch breaks and tea breaks and staff changes over. Surgery is not routine. It's never routine. As soon as you start thinking an operations routine, that's, I think, where problems come in. But to actually have a respectful assistant, following, anticipating, asking knowledgeable questions is very useful indeed. I see our fellow Sensei Ardesh is on. I don't know, Ardesh, if you've been in theatre and assisted at all, or your observations, if you can join us.
All right. Hello, Prof. Am I audible? Sorry, I'm using a new setup.
Yes, you are. You are. Thank you.
Yeah, I've been to the operation theater a few times, but just to observe, not to assist or anything. I think the closest I got to assisting was probably thyroidectomy when the primary surgeon asked me to change the voltage of some probes. I'm not really sure what he asked me to do, but I think that's the closest that I've gotten to.
Okay. But did you notice the interaction between the surgeon and assistant? Did the surgeon have to ask the assistant to do many things, or was the assistant intuitively following?
It was mostly telepathic, if you ask me. It was as if each of them knew what they wanted.
I like that word. It was mostly telepathic.
Yeah.
And in a difficult operation, to have that telepathy, as you describe, can only come by watching operations and understanding the process and the anatomy. But also, even as a new surgeon, if you're comfortable using the instruments, and that's what we are doing in the Black Belt Academy, is teaching you how to use the instruments properly. Put that together with the principles we've described this evening, you'll find that the surgeon and everybody will be quite comfortable. What's interesting, and Sensei Sile and Kadi will answer, that when your assistant picks up an instrument or holds something, within seconds, you know immediately whether you're going to be comfortable with them or not. Just the way they hold, stand, place their hands, and use the instruments. Am I not right, Sensei Kelly? Thank you, Adesh. I like the telepathy. Very good. Prof. Sile, can you spot a good assistant from the moment they pick up instruments?
I think just now you mentioned about that it's a second eye. Assistant is a surgeon's second eye. And then I would say assistant can be the assistant second hand as well. Because when we keep assisting and then we are reading the surgeon's brain and then following his steps. Yeah. So when we are assisting and then following the surgeon's steps, and then we will know later on that what will be his next move.
Yes.
Yes.
Indeed.
So in that case and when we know that what is next move, and I anticipated what instrument he will be asking.
Yeah.
Yes. So it's like, for example, in the theater, my mentor, Prof. Siva, he, not like other surgeons, he uses a certain instrument. For example, it's like just now I saw you use the right angle. Yeah. All right. So he used a right angle and he used a small, tiny Ushida's retractor to retract the ureter, so that Ushida must be in the theater. So it's like when he start looking for the opening up the posterior leaf of the broad ligament, and then he might say that, Sile, what I'm looking for. Then I will answer, Prof, you are looking for ureter.
Yeah.
Yes, ureter. Then I start asking my nurse, do you have a Ushida ready? So that then he mentioned that very good. Like just now you mentioned very good. Yeah. So it's perfect. Something like that. So that his words, his appreciating words, is like very motivation to me.
Yes.
Yeah. But sometimes some surgeon, I'm sorry, they say, I'm the surgeon. I know what instrument to ask. Yeah. So that is just a different, being a good mentor and normal mentor. I don't know how can I put it. But it's like in my experience, and then we gone through various type of surgeons. Some surgeons are very good and very fast in operating, and then but the thing is that when they become a moody, and then it's like sometimes they don't listen the anesthetist. I must tell, sorry, assistant. They don't listen anesthetist, they don't listen the assistant. So what happened that I have my colleagues have an experience, and then she reminded, oh, this is the ureter, but the surgeon say, I know what is ureter. And then suddenly cut it off. Then this ureter transected. So this is very bad. So that's why the surgeon should respect the anesthetist as well. All right. Maybe you can tell, yeah. Or I would say thank you.
Indeed.
Yes, yeah. So these are the so important, how to communicate each other, understand each other, and respect each other. Yeah, that's my contribution.
Indeed. Thank you very much indeed, Prof. Sile. So are there any other questions from anybody watching or any comments to be made? I'm also reflecting on the time that I worked with Professor Sir Magdi Yaqub, and he always played classical music in theatre. So one of the things we all did was have a list of his composers and artists that play, because they'd often ask you, what's this piece of music? And Jacqueline Dupre and her cello pieces were some of his favorite. And that was a nice way of actually initiating conversation with whom I think is one of the greatest surgeons I've had the privilege of working with. So with that, ladies and gentlemen, thank you very much indeed for joining us in the Black Belt Academy. I'd like to thank our surgeon this evening, Alistair, for operating. he will not be doing this again as he goes on his travels and to university later on this year. So thank you very much, Alistair. Excellent skills, and you will get your certificate as a significant contributor to the Black Belt Academy. Thank you very much indeed for joining us. We will see you next week as we continue discussions. We have a feedback form that we're grateful that people could take a moment to fill in. We're very interested in your thoughts and look forward to seeing you next week. Thank you, Sensei Kedi and Sensei Sile, for joining us this evening, and Sensei Ardesh for introducing telepathy as part of this. I hope it's been useful. We wish you well and see you next week. Thank you, Dr. Apajita in New Delhi for the production.